Good afternoon. Thank you all for joining this lecture on creating a culture of continuous improvement. My name is Bennett. I am the Assistant Chief of the Spinal Cord Injury Center at the Veteran Affairs Hospital in Dallas, Texas, and I have no financial interest to disclose. Thank you for joining me as I share my experience from Dallas. I hope that the information presented here will be helpful in stimulating discussions and ideas at each of your facilities. Today's objectives include sharing some organizational, management, and cultural change strategies we have implemented. These strategies have helped us strengthen the use of our outcomes in sustaining a culture of continuous improvement. We have attempted to create a framework which allows for a free flow of ideas to be communicated using a vehicle that leads to program development, new initiatives, and overall growth in our SCI Center. Idea development is a critical part of our strategic plan. Many of these ideas come from frontline staff, they evolve into initiatives, and are a critical part of our strategic plan. Our plan is discussed among our staff routinely and also presented monthly during our regular staff meetings. I would like to share this quote from Eric Shinseki, the U.S. Secretary of Veteran Affairs. He said, "What is most needed are people who are regularly, habitually, and deliberately kind. People who make caring for others a personal devotion, a part of their everyday lives." This quote from Secretary Shinseki gives life to the professional practices we might consider that serve our organizational values of integrity, commitment, advocacy, respect, and excellence, the values of our spinal cord injury system of care, and the specific values we identify and articulate within our SCI Center. Oftentimes, when human beings see data or evidence, it does not always automatically translate into a big push for positive change or improvement. What I'm hoping to share with you today is our story of both the technical and intentional management and quality improvement strategies, as well as motivational and cultural strategies we have implemented to fully engage all interdisciplinary SCI staff. I hope that the strategies presented to you today reflect the continuous feedback opportunities which assist us in making ongoing changes. What I am presenting today is just one snapshot of a continuously unfolding process. We realize the importance of formalizing a management structure that would provide a framework to allow ideas from frontline staff to seamlessly develop into initiatives. I will now present some more technical information about how we designed our SCI management structure in a way to engage our interdisciplinary team in creating a culture of continuous improvement. Keeping in mind our mission to provide compassionate care to veterans and appreciating that the delivery of patient care is enhanced by creating an environment that fosters collaboration, we redesigned our structure to create one that allowed for a higher level of involvement and sense of ownership among the SCI team members. I hope that this section of our presentation can demonstrate to you how we created a management structure to engage and empower the interdisciplinary providers. This in turn has enhanced the ability of frontline staff to provide and generate improvement ideas and carry out quality improvement projects to transform their ideas into reality. Each SCI clinician has ownership in the growth and the development of our SCI Center. This slide here shows members of our Oversight Council. We meet monthly and include a variety of team members. The team members include our Spinal Cord Injury Chief, Assistant Chief, Administrative Officer, Clinical Operations Manager, our Management of Information and Outcomes, or MEO Coordinator. Our group also includes members from nursing leadership. It includes the Deputy Assistant Director of Nursing for the facility, the Associate Chief of Nursing Services, our Spinal Cord Injury Nurse Manager, and Nurse Assistant, and Assistant Nurse Manager. The Oversight Council meets with the 4 oversight committees on a monthly basis to receive progress reports. The quality improvement projects are the main focus of the committee updates. The 4 committees are the Accreditation Committee, the Ops Committee, which stands for Operations, Planning, and Safety Committee, the Q Committee, which stands for Clinical Utilization and Effectiveness, and our Dynamic Development Committee. Each committee has established charters and membership. Other team members and guests are able to join the SCI Oversight Council meetings as needed. This diagram shows the main focus for each Oversight Committee's charter and outlines the areas in which the committee might complete quality improvement projects. The Accreditation Committee members, for example, are always apprised of the most up-to-date standard for relevant accreditation bodies, such as CARF, the Joint Commission, OIG, and our stakeholders, such as the Paralyzed Veterans of America. The Accreditation Committee ensures that the SCI Center's practices are consistent with these standards at all times. The next committee is the Ops Committee. They focus on operations, including space planning, equipment, prosthetics, travel, and connecting clinical and administrative operations. The Q Committee focuses on clinical program management, including effectiveness of care and utilization of information. They oversee the process improvement processes and those involving our spinal cord injury outcomes database, which is also known as SCIDU. The Dynamic Development Committee focuses on staff development, patient education, home care, telehealth, among many other initiatives. At any given point in time, there might be a particular focus, such as a CARF survey visit. A particular committee, in this case the Accreditation Committee, would enlist the support of the other 3 committees. And at any given time, any of the committees can choose to form specific work groups to address rapid improvement processes. This diagram shows the actual committee members. The starred members are the committee leaders and attend the monthly Oversight Council meetings to provide committee updates or progress reports. The committee leaders were chosen on a voluntary basis by their peers. Each committee has interdisciplinary representation from the matrix spinal cord injury services. Members include social workers, therapists, physicians, vocational rehab coordinators, nurses, psychologists, and even a chaplain. Additionally, the committees are encouraged to invite other interdisciplinary team members as subject matter experts or consultants as needed. These 4 committees meet once or twice a month, depending on their needs and goals at that time. This next slide represents an example of a charter from one of our 4 Oversight Council committees. I will briefly review the purpose stated on this committee's charter. This is from our Accreditation Committee, and their purpose is to provide oversight to assure that all VA Dallas spinal cord injury services meet the standards of quality such that the center fulfills accrediting criteria and satisfies all stakeholder groups. I have the charters here for each of the committees. For the sake of time, I won't go through them, but all committees did create similar charters that reflect their unique purposes and objectives. We like to think of our oversight committees as kind of think tanks for the SCI Center. We deliberately encourage our think tank members to not get caught up in the minutia of, for example, minute taking or collecting data. Rather, we hope they would focus on developing ideas that would translate into initiatives that would ultimately strengthen the framework of care we provide for our veterans. Now, 2.5 years later, we've looked to see how our committee members viewed the processes and structure in place. SCI leadership met with each committee to obtain open and honest feedback to identify any perceived barriers and also to identify opportunities for improvement. One of the ideas that came from this discussion was to have a formal open season to start the new year and to inspire new frontline staff to join. We also encouraged existing committee members to switch committees. if they felt that would refresh their experience and their commitment. We reminded staff that there was no specific knowledge or skill required to join any of the particular committees. Our hope was that people would be inspired to be creative and to connect with colleagues around the mission and values central to our SCI Center and facility at large. This open season poster was created by Committee D, our Dynamic Development Committee. They used inspiring language and design with this flyer to elicit renewed participation in the SCI Oversight committees this year. We shared this information at 2 consecutive monthly SCI staff meetings. In addition, members of all of the oversight committees took time to visit with the SCI staff to elicit their interest and participation. Now I will take this opportunity to briefly highlight some of the process improvement projects and initiatives that have come from the committees. This slide shows a project from the Q Committee, which again stands for Clinical Utilization and Effectiveness. This committee focuses on ensuring that care is provided in both an efficient and effective manner. They review processes and identify and improve those that are suboptimal. The team anecdotally identified that there was a delay between when lab draws were ordered in our electronic medical record system by the provider and when they were actually drawn by the nursing staff. The team decided they wanted to find out if there was any data, real data, to support this anecdotal evidence. So the Q Committee consulted with our Management of Information and Outcomes Coordinator, or MEO Coordinator. The MEO Coordinator helped this committee articulate their design and then liaison with a resource in our hospital called QUANTS, which stands for Quantitative Analytics for North Texas Statistics. It is a section of our research service that is dedicated to assisting services with quality improvement projects. The team requested a baseline data report. This report indicated that there was indeed a delay in some of the stat and now lab draws consistent with the anecdotal evidence. As an interdisciplinary team, which consisted of a physician, physical therapist, nurse, and psychologist, they devised an intervention consisting of educating the nursing staff on setting an alert in the electronic medical record that provided written notification of newly placed lab orders. The nurse on the team provided this education to the inpatient nurses during an educational fair. This intervention was in place for about 6 months. Then the team requested a repeat data pool and analysis from the Quants team. The results indicated that there was a statistically significant decrease in delays associated with labs ordered and drawn on the SCI inpatient service. A second follow-up analysis was requested from the Quants team at 1 year post-intervention to examine the sustainability of these improvements. This is one example of how a collaborative, interdisciplinary effort was needed to fully understand our processes, identify areas that can be improved upon, and to ensure successful implementation of the recommendations. Having our frontline staff involved in this process helped secure buy-in from the team, especially the nursing staff who participated in this intervention. The next slide shows an example of a project from our Dynamic Development Committee, which focused on the Health Buddy, which is an electronic device that allows patients to input health data from home, such as blood pressure and blood sugar readings. This committee wanted to know if the use of the Health Buddy resulted in a decrease in emergency room visits and a decrease in hospital length of stay for patients with diabetes. Based on the results, they expanded the program by identifying more patients who were eligible for participation in the program. They increased the level of patient and caregiver education on the benefits of the Health Buddy, and they also encouraged stronger compliance with Health Buddy reporting. This is a project completed by the Accreditation Committee. They became aware that there were some unnecessary delays in discharge from the inpatient rehab program. They identified factors that commonly led to a delay in discharge and took steps to correct them. As a result of this project, the interdisciplinary team is more proactive in addressing patients' needs earlier in the rehab stay in order to ensure that discharge delays are avoided. Our Dynamic Development Committee identified a need to develop an outpatient wound care clinic to improve access to the evaluation and treatment of decubitus ulcers. Subsequently, a wound care clinic was established. They met their initial goal of 80% clinic utilization, and now clinic utilization is consistently above 100%. This is an initiative started by our nursing service to look at ways of preventing catheter-associated urinary tract infections, or CAUTIs. A CAUTI prevention bundle was developed, frontline staff and patients were educated, a CAUTI champion was identified. The result was a significant decrease in the incidence of catheter-associated urinary tract infections. This next project centered on ensuring that all veterans with SCI were classified correctly in regards to their problem list in regards to their SCI diagnosis. The primary purpose of this project was to ensure that all veterans with spinal cord injuries were seen at least annually, if not more often, in our system. In addition, this initiative allowed for appropriate allocation of funds, resulting in increased reimbursement to our healthcare system. Ideas often come from a number of different places, and one that seemed to be talked about a lot was noise, not only in our spinal cord injury center, but in many parts of our hospital. The inpatient spinal cord injury unit was the second inpatient area at our facility to volunteer to utilize a sound ear sound lock system, which you see pictured here. This system measures and provides real-time feedback about the level of noise on our unit. We use the acronym Silent Hospitals Help Healing, or SHUSH, to create awareness about noise from people as well as doors, equipment, etc. on the unit. We looked at our baseline data in comparison to EPA and World Health Organization recommendations about noise levels in the healthcare setting and realized that there was room to improve. This resulted in a nurse's suggestion to develop a new call light response system to decrease overhead paging on our unit. Besides our think tanks, we have additional opportunities for staff to share ideas. These include our inpatient operations meeting, outpatient operations meeting, nursing physician forum, SCI staff meeting, and SCI home care meetings, all of which occur at least monthly. Veterans and staff can also share ideas via a reflections box on our unit. We decided to veer away from the word suggestion and wanted to encourage thoughtful and inspired feedback. Our reflections box contains note cards for reflections to be written. They are collected monthly and distributed for review by our SCI think tanks based on subject matter. We have also installed a huddle board in our center to collect ideas from frontline staff. All disciplines have access to this white marker board to submit their ideas in writing. Staff can identify areas of concern or areas that are in need of improvement on a daily basis. The team huddles around this board daily to devise plans for addressing the identified concerns. Patients can see this board as well so that they too are aware of our culture of continuous improvement. Veteran feedback is also elicited during their participation in our spinal cord injury and multiple sclerosis peer support program, our PVA site visits, and our SCI Internet Volunteer Cafe volunteer program. Additionally, veterans participate in formal weekly leadership rounds with nursing and SCI leadership. The two initiatives, National VHA initiatives listed here, shape our integrating outcomes efforts in Dallas. They help us keep focus on specific opportunities, strategies, achievements, and long-term goals for SCI. The MEO and iCare values guide us to create our own culture of continuous improvement in service of helping veterans optimize their rehabilitation, live independently with dignity, and have the support to pursue what is important to them. The iCare and MEO initiative supports also help us focus on strategies to create information transparency and accessibility for patients, providers, administrators, and leaders within our facility. These initiatives and supports really support our values and are empowering us to better communicate information about our compassionate work to the very people we are trying to help. I want to take a few minutes to talk about the specific attention at our center to the MEO initiative and integrating SCIDU and outcomes into general care. This slide attempts to show how our integrating efforts support an ongoing transformation in how providers perform assessments, structure formal and informal team interaction, develop patient-centered goals, access outcome information, and ultimately use outcomes towards program improvement. By fully integrating the outcomes on a patient level and housing them in our database known as SCIDU, our outcomes-oriented care delivery strategy produces the program outcomes. This process supports the team in actually using those outcomes towards continuous improvement. In trying to do this, we started at a patient level. On the left side of the slide, you see a SCIDU-generated progress note where the inpatient team has incorporated the Functional Independence Measure, or FIM, start, goal, finish, and 90-day follow-up information into the interdisciplinary team node. Below that is the colorful graph from SCIDU, which shows how this particular patient has improved during and after the rehab process. This type of viewing of individual patient outcomes is further enhancing the team's ability to quickly interpret patient progress and to determine the need for further intervention. On the right side of the slide, you see the program outcomes. Our team committed to using SCIDU to integrate individual patient outcomes into their care. Then the automatic byproduct of doing this was having the up-to-date program outcomes available to the team at all times. We won't go into details at this point, but SCIDU allows each clinician to quickly access inpatient rehab outcomes for any date range within a matter of seconds. The program outcomes you see on the right are routinely accessed and displayed during our team meetings to stimulate discussion and utilization of these outcomes. The team also created ways of communicating to make the overall interdisciplinary team meeting more efficient. Examples include creating an Outlook email group for the rehab team only, and also creating an Outlook meeting request for our team meetings, and developing a detailed interdisciplinary team weekly schedule with 5, 10, or 15 minutes scheduled for each patient, depending on the type of case being discussed, whether it be a new rehab admission, an ongoing IDT case, or a discharge review. The team also created a protected network shared folder to share patient information with our case manager. We did not intentionally set out to improve our team communication, but it was a positive, unexpected byproduct of focusing on integrating core outcomes assessments into the inpatient and outpatient rehabilitation care. I'm going to return to this quote from Secretary Shinseki about making care for others a personal devotion and part of our everyday lives. Not only do we turn to inspiring quotations and prose to illustrate the human story aspect of our work, we also turn to videos and other resources to help us pause and reflect on what motivates us to do our work. We include specific items and experiences in our SCI staff meetings to help us all reflect on these ideas about personal and organizational values and why we are here. In other words, we have attempted to start the conversation. This slide contains more stories and resources we have used for staff development during our monthly staff meeting. I would like to conclude our presentation with this video clip we recently shared during a monthly spinal cord injury staff meeting about a veteran who overcame chronic illness. While this veteran does not have a spinal cord injury, it still articulates the striving for wellness and meaning which we all hope to support for the veterans we serve. It is the video which has probably resonated the most with our staff. It spoke to how our beliefs about veterans we serve really matter and actually impact what a veteran believes about himself. I hope this information presented will be helpful in stimulating discussions and ideas at your centers, and I hope this video speaks to you.